Hi, my name is Whitney Lowe and welcome to the third DVD in my orthopedic massage series. Upper extremity pain and injury conditions are common due to the heavy demands of our daily activities. Chronic muscle contractions and overuse are especially problematic in various occupations. The soft tissues play such an important role in the upper extremities that even motions that don't seem stressful can lead to injury when performed repeatedly. In sports, repetitive motions are combined with high-intensity training, often against resistance. As a result, the soft tissues are vulnerable to injury. The activities we participate in often require awkward positions and repetitive loads, which increases stress on both small and larger tissues. Notably, manual therapy can lead to overuse disorders as well, and you should make sure that you care for yourself for a long and successful career. These DVDs are companion learning tools to my books, Orthopedic Assessment in Massage Therapy and Orthopedic Massage Theory and Technique. You'll find more detailed information about assessment, treatment, and musculoskeletal conditions in these texts. The upper extremity is used extensively in our activities of daily living, and there are numerous muscles and soft tissues that can be injured in this region. Muscles, such as the rotator cuff group, must withstand high force loads and repetitive motions. These mechanical burdens often lead to soft tissue injuries in the shoulder. The Apley scratch test is used to assess shoulder motion and is usually used to evaluate capsular and non-capsular tissues limiting motion in the glenohumeral joint. The shoulder has the greatest range of motion of any joint in the body. Its movement and stability are governed by numerous muscles. However, it is also one joint where motion can be mostly limited by the joint capsule. Motion restrictions that affect the joint capsule are evident in the joint's capsular pattern, which is evaluated in the Apley scratch test. Begin the procedure by having the client turn around so you can observe the position that their hands are in. One arm is brought into abduction and external rotation, the other into adduction and internal rotation. If you see a limitation in the sides, this may be indicative of a shoulder pathology. The best way to see that and evaluate is to compare the opposite side. Let's do that now, Bailey, switching arms. This time, this one will be brought into abduction and external rotation, the lower one into adduction and internal rotation. Hold that position for a moment. If there's problems getting this arm into the abduction and external rotation, this will be indicative of a problem oftentimes with the capsule or other tissues that are limiting the abduction and external rotation in the shoulder. If a person has a problem getting this arm back up behind their back, or you see a very significant difference between where their fingertips reach in the two tests, it may be a problem with the other or opposite muscle groups. For example, some of the muscles that would limit the ability to adduct or internally rotate the shoulder. So this can give you information about either one of these shoulders and some of the different tissues that might be restricting range of motion. The drop arm test investigates the presence of rotator cuff tears. This test is most accurate if the tear is moderate to severe, so keep in mind there could still be a rotator cuff tear present even if there isn't a positive result on this test. The supraspinatus is the most commonly torn of the rotator cuff muscles. The reason it is so commonly torn is that it gets compressed and frayed as it rubs against the underside of the acromion process. In this procedure, we're going to begin with our client's arm in abduction. And first, just look, Bailey, hold your arm right here in that position. I want to see if she can even hold in this position. If they're having trouble even holding in this position, that could be evidence of a significant rotator cuff tear. The next step, however, will be to tell the client to slowly lower her arm down. And as she slowly lowers it down, I'm going to give a little punch or push with my fingertips to push it down. Her natural tendency is going to be to push that arm back up because I instructed her to hold it there and slowly drop it down. But if there's a significant rotator cuff tear present, when I give that little push, her arm will often rapidly drop down to the side and she won't be able to hold that position. What's occurring here is a procedure or a principle called reflex muscular inhibition. With the rotator cuff tear, when I give that sudden load to it, the pain comes on very suddenly and it shuts off the neurological activity to the muscle, forcing the arm to drop down to the side. This will be indicative of a significant rotator cuff tear. The Hawkins-Kennedy test is commonly used to evaluate shoulder impingement in the subacromial region. Several structures could produce pain in this region, so it's important to use this test in conjunction with other evaluation procedures. In the shoulder, the coracoacromial arch is composed of the coracoid process, coracoacromial ligament, and the acromion process. Numerous soft tissues lie under this arch and are susceptible to compression. They include supraspinatus tendon, tendon from the long head of the biceps brachii, and the joint capsule of the glenohumeral joint. The subacromial bursa lies above the rotator cuff muscles but under the acromion process of the scapula. When not inflamed, it is actually a very thin structure, and its primary function is to reduce friction of the supraspinatus against the acromion process. Begin by bringing the client's arm up into a full forward flexed position, and from that position simply internally rotate to the end of the range of motion. If this procedure reproduces pain in the subacromial region or the anterior shoulder, it could be indicative of subacromial impingement. Again, we bring the client's arm up into full forward flexion, it's straight in front of her, and then from that position into internal rotation. Note that some people will report some discomfort on the posterior shoulder, and that is not necessarily indicative of subacromial impingement. That's often stretching of the rotator cuff muscles on the posterior side. If there is impingement, the pain is likely to be in the subacromial region or around the front side of the shoulder. The Hawkins and Kennedy test, as we mentioned, should be used with other evaluation procedures to identify which of the tissues in the subacromial region is causing the discomfort. The empty can test is one of the most common procedures for evaluating subacromial compression. While the test evaluates several structures, there is a greater emphasis on assessing compression on the supraspinatus. Have the client bring both arms into a position of full abduction and then horizontal adduction about 30 degrees. From this position, I'll have her turn her hands or shoulders into internal rotation as if emptying a can, which is where the test gets its name. Then apply pressure straight down on the humerus above the elbow, and just, Bailey, hold that position there, and I'm going to press down with a moderate degree of effort. Good. And I'll identify if there's any pain or discomfort felt in her shoulders with this procedure. Any pain or discomfort that's felt in that region could be indicative of shoulder impingement. Now, in this position, let's come back into the test position once again. She may feel pain at any point in there, but if she does not feel pain until the very last step, when I push down, that's when it's most indicative of supraspinatus involvement, because at this point, the supraspinatus is being recruited to resist the pressure that I'm placing down on her arm. So this could be indicative of subacromial impingement at any step along that test, but the very last step is the one that gives us the most information about the supraspinatus. The near impingement test also evaluates subacromial impingement. However, it puts more emphasis on structures that are likely to be impinged beneath the coracoacromial ligament, such as the tendon from the long head of the biceps brachii. In this test, I'm simply going to bring the client's arm into full forward flexion as far as possible, and to see if that reproduces pain. Bringing her arm up into that full forward flex position can pinch or compress those structures underneath the front side of the shoulder. It's usually the tendon from the biceps brachii long head that's affected here when it's impinged under the coracoacromial arch. Again, fully bringing that arm up into forward flexion as far as possible and seeing if that reproduces the client's pain or discomfort. Most indicative for compression on the anterior side of the coracoacromial arch. Speed's test is a valuable method for evaluating dysfunction of the tendon from the long head of the biceps brachii. It is used most often to address the possibility of bicipital tendinosis or bicipital tenosynovitis. The tendon from the long head of the biceps brachii courses through the narrow bicipital groove on the anterior aspect of the shoulder. Due to the amount of friction and high tensile loads placed on the tendon, it is susceptible to tendinosis. The upper portion of the tendon has a synovial sheath, which may also develop tenosynovitis, an irritation or adhesion between the tendon and its sheath. Begin with the client's arm in a fully flexed position. Remember, the tendon from the biceps brachii goes through the intertubercular groove or bicipital groove in this area here. I'm going to have her hold her arm in this position. Also keep in mind that the biceps brachii has three main actions: shoulder flexion, elbow flexion, and supination of the forearm. So we're going to resist all three actions simultaneously. Bailey, I want you just to hold your arm here and don't let me move it. By placing my hand here and pushing down on her distal arm, I'm having all those actions engaged simultaneously. And I'm going to find out if there's any pain reproduced in her anterior shoulder from this position, and then also tell her just to slowly let go of that, and I'm going to push down as we go down in this position. She's still engaged in some contraction as we begin to go down, but the fact that I'm pushing down against it and engaging the resistance simultaneously is sort of dragging that bicipital tendon through the groove with a bit more tension on it than normal, and will often reproduce pain if a person has bicipital tendinosis or tenosynovitis affecting that tendon. The crossover test evaluates damage to the acromioclavicular ligaments. This type of injury is also called a shoulder separation and usually occurs from a fall directly on the shoulder or an impact to the acromioclavicular articulation. The clavicle is connected to the acromion process by the acromioclavicular ligament. A shoulder separation is a sprain or tearing of this ligament. The coracoclavicular ligament may also be damaged if the sprain is severe. In this procedure, we're going to simply close off this area here, and this test can be performed either actively or passively. The client can do this themselves, or the practitioner can perform the motion. Bring the client's arm fully across the upper chest in a position of horizontal adduction as far as possible. And we're looking to see if that position reproduces pain at the acromioclavicular articulation. If it does, this is indicative of potential sprain or overstretching of those ligaments. Again, up in this position and fully horizontally adducted across the front side of the body. And if it's reproducing the same pain or discomfort right at that acromioclavicular articulation, this is indicative of possible shoulder separation or overstretching of the acromioclavicular ligaments.